I'm sure there will be questions, so we open the floor for...
Oh my God.
Are you ready?
No.
Don't fight.
fight.
Don't fight.
Okay, Stacey.
Stacy Lindsay, Cholangiocarcinoma Foundation. So I have several thoughts on this, but this is the wild, wild west in the U.S., and we had Dr. Herman give a webinar last year when this was first, right, when it was coming out. We had thousands and thousands of patients view that webinar. There was a ton of interest. And I think you were a great presentation, but I think for the patients, I think it would be helpful to know what is not acceptable for histotripsy. Because we see a lot of patients, as a matter of fact, at our conference a few weeks ago, one of the patients stood up and said, in the next couple of years, we won't have any need for surgery because histotripsy is going to take care of it. So I just, if you could just share, because I think they have very good marketing. It's very good marketing, and they're marketing to the patients. And what we need to see is data. And so to be, right, we all want the patients to be safe. But again, in the US, we all want to see that the patients want to take risks. Like we heard some of the patients share in their testimonials is that they're willing to take the risk because their options are so few. So would you mind sharing some of the things that you would see, like peritoneal spread, what can you not do with histotripsy?
So, great question. That's actually probably one of the most important questions in the country right now. So if you survey the providers in the country, they'll give you different criteria for who can be eligible and who's not eligible. So at the end of the day, you can treat anything that's about 12 centimeters in depth in the liver, that's not too high by the lung. So one is location. So if it's high by the hepatic dome, the lung, the air in the lung prevents the ultrasound waves to hit that area. So by the limitation of the location by the hepatic dome, that may preclude histotripsy by location in that scenario. But short of that dome location and the depth, the 12 centimeters, or body habitus, and there's like a physical limitation how deep you can go based on the patient's depth and the tumor location, you can treat any liver lesion. The question is, should you treat? That's the bigger question, right? So that's a much harder question. So if it's a solitary liver lesion under 3 centimeters, that's reachable. I would argue that that is treatable for patients who are not maybe the best surgical candidate, because you don't get the lymph node staging by treating the liver only. You don't get the lymph node sampling, so you can understage the patient. If you have patients who are widely metastatic, who come to you, who's refractory to everything, I think it's important to know that you shouldn't use histotripsy as a solitary treatment, that you should add it with some treatment in combination with immunotherapy or another chemotherapy regimen. Like a lot of times patients say, I don't want chemo and I just want histotripsy. Yes, you can do that, but I think that's ill-advised. I think that the treatment will always work better with adjunct immunotherapy or chemotherapy for cholangio, and a solitary histotripsy for metastatic cholangio for peritoneal spread. I think, for me, I have a hard time agreeing to that. Things that are more distal should be surgically excised, that it can be potentially curative. That by the distal or mid-common bile duct cholangios, those should be surgically excised. The hilar region, I think the area that I foresee this working the most is if they're metastatic with hilar disease, this area is going to be very helpful to decompress the hilum to prevent cholangitis. If it's a solitary hilar lesion that's locally advanced, you can do that in combination with surgical resection. So I think it's a difference of opinion, but I think there's a lot of reasons why patients come to us with expectations that we're going to treat them. And there was a patient that I said, hey, you're actually responding great to chemotherapy. You have CA19-9 regressing, the lesion's getting smaller. Why don't we not do the histotripsy yet? Because there's no signs of worsening. The downside of doing histotripsy can sometimes be that you have this acellular lysate that can be a source of a hepatic abscess. So we put patients on 4 weeks of oral antibiotics to prevent liver abscess. So for that one particular patient, I said, listen, you're doing well, responding. I have a hard time treating you, even though I can hit it just fine. If I create a liver abscess, then I will keep you from getting chemotherapy that's working for you. So I said, you are eligible, but not now. I would hold off. So
We have a lot of questions, so maybe Professor Khan could take you first.
Fascinating talk. So I've got a few questions, most of which are just yes or no. So you're not limited by adjacent structures.
no.
Are you limited by size of the lesion? Yes or no, and what's the size?
3.5 centimeters.
It's always 3 centimeters, isn't it?
Yeah.
And are you limited by liver function? By the MEL score or Child Pugh score? Is that an issue?
So
that you worry
we
about?
try to avoid child C because you still cause liver injury, but child B and A, no problem.
Okay.
Bilirubin 4, 5, we've kind of raised the limits and people have done fine from that.
And does it need to be done under GA, general anesthetic?
Yes,
Okay.
that's it.
So
I take that back. So I do it under general anesthesia with extensive paralytic. There are patients and other centers that do it in interventional.
yeah.
So the reason why I think it's helpful is that if you're paralyzed, there's a couple of maneuvers you can do to help. Well, they don't move first, but you can also play with the tidal volume.
Yeah.
So if you have a hard time getting up to a lesion that's higher up, if you increase the tidal volume, they actually can bring the liver down and bring it just into view.
Sure.
And then you can minimize the mobility by just decreasing the tidal volume that way too.
And can you use it to treat tumor thrombus?
So it actually can cause a portal vein thrombus, and yes, but it can also cause thrombus as well. So we actually get CT scans to make sure that if they cause a portal vein thrombus, that we actually put them on blood thinners. So,
Okay, last question, I promise.
Yeah.
Right. I understand that you're not going to have any long-term data, but surely there's been enough for some short-term data, recurrence data at a year.
so the 1 year data from the Hope for Liver trial came out 90% local control rate at 1 year. So that's a trial that caused FDA approval. So 1 year out, 90% control in that initial 95% plus population. So that's
Okay.
How
Thank
many
you.
patients? Oh, sorry.
Yes,
42,
please, yeah.
42, whoever asked.
Yeah.
In that trial, how many patients were suffering from cholangiocarcinoma? Hi, I'm Barbara over here.
I'm sorry, what?
HPV
It's
surgeon.
difficult with the
How many
lights.
patients in that trial were suffering from cholangiocarcinoma? In the
It
one-year
was mostly
results?
ACC and
Yeah, exactly.
colorectal, so small
Yeah.
percent.
So you've treated patients with distal mets, as I understood, also the lung metastases. I was wondering, what is the amount of tissue you'd like to treat in one patient at one time? Did you do multiple lesions, for example, in one patient? What is
Right.
the safe amount of disease? As I consider, you do kind of a debulking procedure since you're continuing chemotherapy,
Right.
right?
So great question. So that patient with the abscopal effect, it was one solitary lesion. But I generally limit myself to 3 lesions with a 3.5, 4 centimeter ablation zone because you are essentially creating a hole in the liver, so you do cause liver injury. There was one patient that I had AKI post with a high voltage setting for pancreatic, highly desmoplastic fibrotic. So when you tailor the treatment to increase the voltage to see the microbubble,
Yeah.
the voltage was higher than the average, and that patient ended up having AKI, which resolved on its own, but because
I
of that.
understand, yeah. I've seen that complication before. The other question, my last question, sorry for that. If you compare it to IRE, irreversible electroporation, what do you think about that? I mean, we've tried it in cholangiocarcinoma. Our institute is quite advanced with it?
If I can just interject here, if you can be very brief, because we're being flagged for lunch, and I'm sure you'll be staying for lunch, so questions can. Oh, and we have John.
So
Can
quick,
we give 5 more
so
minutes?
quick answer. So I was at University of Louisville
Five more
with.
minutes, and then we have to. Yeah.
So I was at University of Louisville with Rob Martin, who's the IRA guy, right? So I use IRA extensively. Once I saw histo, IRA became a lost thought. The night and day difference between the immediate tumor dissolving, the whole point of the IRA is to preserve the vasculature. Agree. But the immediate liquefaction of the tumor and the abscopal and immunoactivation is nowhere in comparison to the IRA data that we did in the lab, in his lab. The mirroring data for the immunotherapy is not as strong.
Okay, thank you.
We have multiple questions online, so very quick fire answer for this. Is histotripsy available in the UK or the rest of Europe, and is the EMA interested in improving it? Quick answer.
April 30th, we have approval in the UK for select NHS and private sites. So they issued the letter a couple of weeks ago, the MHRA.
Okay. Second question, how many treatments of histotripsy constitutes a course, or is it a one-off treatment?
So in one setting, you can do up to 3 or 4 if it's smaller lesions, and you can do it every month.
Okay. And then a question from myself and Heinz Joseph, how far away are we from a trial with survival outcome data?
So there's an ongoing trial through the company that's doing prospective survival data. So the 1-year survival from the trials just came out. So all the collaborative centers are doing the data collection as we speak.
And then maybe last question. Okay. Question. How many questions have we got from the floor? We've got maybe 2 more minutes. Yep.
Just a couple of points of clarification. Very interesting. Thank you. It depends on your definition of abscopal, but all that abscopal stuff you called, that was murine, wasn't it? None of it was in a human being.
The patient was a human being.
No, you showed
So all the published data was mirroring.
Yeah.
Yes.
Okay.
Yes.
So sort of depends how you define abscopal as well, but that's another conversation. And then on your very original slide, the 42 out of 44.
Correct.
And you had 95% success. What do you define as success?
So post
I mean,
radiographic
is that
imaging. Post radiographic treatment demonstrating no enhancement of any residual tumor. So radiographic independent validation post treatment.
So immediately post treatment. So there's no follow up data to that.
There is follow up data.
But nothing. I mean, as I understand it, there's no trial as such. Is that right?
So the 1-year data from those patient cohort came out that shows 90% local
But
disease
that's-
control of the treated areas.
But that's a patient series. It's not what we would consider a trial.
So Hope for Liver trial was a trial of 44 patients. So if you're asking in a head-to-head trial, no. So this was a feasibility and safety trial. So I think you bring up a very good point. So in the world of histotripsy, there's show me the data and show me the science. And so that actually will happen as we speak. Will we wait 5 years for a head-to-head trial? I don't think so.
Okay, well, that's been absolutely fascinating. Thank you for being
Yeah.
brave enough to sit here and be grilled. And I'm sure that people will speak to you over the lunch, and I hope you're receptive to that. But thank you so much for coming all this way to explain histotripsy.